Drug interactions of antidiabetic drugs. Drug interactions with antidiabetic drugs may produce hypoglycemia or hyperglycemia by affecting drug metabolism, insulin secretion, or glucose regulation. Insulin and drugs causing hypoglycemia. One important cause of insulin-induced hypoglycemia is interaction with other drugs that can either enhance insulin action or make hypoglycemia harder to recognize. First, beta blockers can mask important hypoglycemic symptoms such as palpitations and tremors. They may also potentiate the insulin effect, increasing the risk of severe hypoglycemia going unnoticed. Next, ACE inhibitors enhance insulin sensitivity and improve glucose uptake by tissues, which can further lower blood glucose levels. Alcohol is another important interaction. It inhibits hepatic gluconeogenesis, reducing the liver's ability to release glucose and thereby deepening hypoglycemia. Finally, salicylates increase insulin secretion and peripheral glucose utilization, further enhancing glucose lowering. Insulin and drugs causing hyperglycemia. Now let's discuss drugs that can cause hyperglycemia and therefore reduce the effectiveness of insulin therapy. First are corticosteroids. These drugs promote gluconeogenesis in the liver and increase insulin resistance, resulting in higher blood glucose levels. This is why diabetic patients often require higher insulin doses when receiving steroids. Next are thiazide diuretics, which can reduce insulin secretion from pancreatic beta cells and thereby impair glucose control. Sympathomimetics, such as adrenaline, stimulate glycogenolysis and gluconeogenesis, increasing glucose release into the bloodstream and causing hyperglycemia. Finally, oral contraceptives may impair insulin sensitivity through estrogen and progesterone effects, leading to reduced glucose utilization. The key message is that these drugs can antagonize the glucose-lowering action of insulin and may necessitate closer monitoring and dose adjustment in diabetic patients. DPP-4 inhibitors. DPP-4 inhibitors generally have few drug interactions, making them relatively safe and convenient to use. However, there are some important exceptions that should be remembered. One classic interaction involves saxagliptin and ketoconazole. Saxagliptin is metabolized by the CYP3A4 enzyme. Ketoconazole is a strong CYP3A4 inhibitor, so it reduces the metabolism of saxagliptin. As a result, saxagliptin plasma levels increase, which may enhance its effects and adverse reactions. Another important interaction is with rifampicin. Rifampicin is a potent hepatic enzyme inducer. By inducing drug metabolizing enzymes, it increases the metabolism of several DPP-4 inhibitors and thereby decreases their effectiveness, leading to reduced glycemic control. GLP-1 receptor agonists and SGLT2 inhibitors. Now, let's look at the important drug interactions of GLP-1 receptor agonists and SGLT2 inhibitors. Starting with GLP-1 receptor agonists, these drugs cause delayed gastric emptying. As a result, the absorption of co-administered oral drugs may be reduced or delayed. This interaction becomes particularly important for medications where precise absorption is critical. Another important point is that when GLP-1 receptor agonists are combined with insulin or sulfonylureas, the risk of hypoglycemia increases because the glucose lowering effects become additive. Moving to SGLT2 inhibitors. Combining them with diuretics, there is an increased risk of dehydration and hypotension due to excessive fluid loss. In addition, when SGLT2 inhibitors are used together with insulin or sulfonylureas, can also increase the risk of hypoglycemia, often requiring dose adjustment of the accompanying agent. Sulfonylureas and drugs causing hypoglycemia. One of the most important adverse drug interactions with sulfonylureas is the development of severe hypoglycemia. This occurs when certain drugs either displace sulfonylureas from plasma protein binding sites or inhibit hepatic metabolism, leading to higher plasma levels of sulfonylureas. Several drugs share this common mechanism. These include salicylates, warfarin, sulfonamides, azole antifungals, and fluoroquinolones. By increasing the amount of active sulfonylurea in the circulation, they enhance insulin secretion from pancreatic beta cells and can precipitate severe hypoglycemia. Clinically, this interaction is particularly important in elderly patients and those with the renal impairment, where hypoglycemia may be prolonged and dangerous. Sulfonylureas and drugs causing hyperglycemia. Now let's discuss drugs that can cause hyperglycemia and reduce the effectiveness of sulfonylureas. A major mechanism is the induction of hepatic drug metabolizing enzymes, which increases sulfonylurea metabolism and lowers their plasma concentration. Important examples are rifampicin, phenytoin, and carbamazepine, all of which act as enzyme inducers and can reduce the hypoglycemic effect of sulfonylureas. Other drugs increase blood glucose through different mechanisms. Glucocorticoids increase hepatic glucose production and promote insulin resistance. Thiazide diuretics reduce insulin secretion from pancreatic beta cells. Oral contraceptives can impair insulin sensitivity, leading to insulin resistance. Metformin. Metformin is unique among anti-diabetic drugs because it has minimal drug interactions, largely because it is not metabolized in the liver. However, there are two clinically important interactions that every student should remember. The first is alcohol. Alcohol impairs hepatic lactate clearance, leading to accumulation of lactate in the body. When combined with metformin, this increases the risk of lactic acidosis, a rare but potentially serious adverse effect. The second interaction involves iodinated contrast media, which may cause acute renal impairment in susceptible patients. Reduced renal function can lead to metformin accumulation, further increasing the risk of lactic acidosis. Clinically, metformin is often withheld before and after contrast-based imaging procedures until renal function is confirmed to be normal. Pioglitazone. Now let's discuss the important drug interactions of pioglitazone. One clinically significant interaction occurs when pioglitazone is combined with insulin. Both drugs improve glucose control, but this combination increases the risk of fluid retention and heart failure. Therefore, patients should be monitored for edema, weight gain, and signs of cardiac decompensation. Next, gemfibrozil inhibits the CYP2C8 enzyme, which is responsible for pioglitazone metabolism. As a result, pioglitazone levels increase, potentially enhancing both its therapeutic effects and adverse effects. In contrast, rifampicin induces CYP2C8, accelerating pioglitazone metabolism and decreasing pioglitazone levels. This may reduce glycemic control and necessitate dose adjustment. High-risk combination summary. Let's conclude with a high-risk combination summary, highlighting some of the most clinically important anti-diabetic drug interactions. First, Insulin plus beta blockers is a potentially dangerous combination because beta blockers can mask hypoglycemia symptoms such as tachycardia and tremors, delaying recognition of low blood glucose. Next, SGLT2 inhibitors plus diuretics can cause compounded fluid loss, increasing the risk of dehydration and hypotension, particularly in elderly patients. Another important combination is metformin plus contrast media. Contrast-induced renal impairment may lead to metformin accumulation and increase the risk of lactic acidosis. Therefore, metformin is often withheld before contrast-based imaging procedures. Finally, pioglitazone plus insulin increases the risk of fluid retention and heart failure, requiring careful monitoring for edema and worsening cardiac symptoms.